So during the semester in scenarios, I was presented with a number of asthma cases, and I just thought I'd use Gibbs model reflection now to just reflect on my performances and help give some insight into how they all went into molding my approach now in my critical thinking video. To describe what happened, so obviously, there was a few different scenarios I was approached with. I remember one scenario very clearly was the full asthmatic arrest. So walked in the conscious patient who didn't have too bad asthma, that progressed to an unconscious patient who still had pulse, and then finally, to the unconscious patient losing a pulse in the full asthmatic arrest scenario. So that was one, and had another couple of ones where they were conscious and they didn't get to the unconscious stage. So managing the asthma in a conscious stage, which is quite a sort of straightforward critical thinking model that I would employ there. And there was definitely another one in which case they went unconscious with a pulse but never quite lost their pulse and went into the arrest. So that's just a little bit of what was happening. I remember one was clearly on a patient transport, and I was called in because they were complaining of some struggle in breathing. So I used them, the transporters, as a good information source, and also the patient. So that's just setting the scene for a couple of the scenarios that were addressed. So feelings, what were you thinking and feeling? Well, I guess when it gets to the traumatic arrest scenario, it's a bit of a, where do I start sort of thing, and being able to kick over in your head that you're moving on from an asthmatic approach, and there is an entirely different set of guidelines and rules you have to follow, especially that first one, because I hadn't done cardiac arrest guidelines since earlier on this year in first semester. So that was the first one was terrible. It was really rusty. I forgot a few pulse rhythm checks before doing the 6-second strip printout. So that feeling of holy crap, this is I got to switch gears straight away and manage this patient immediately. But also, those feelings of I feel like I can manage this based on the conscious asthma approach, and I've done it a couple of times during the semester and done some practice outside of uni, and I really think I'm comfortable with managing an asthmatic patient. And obviously, the little tips and the little tricks, which I'll talk about a bit later. So I guess, it's getting ready and coping with that stressful situation if it does end up at an asthmatic arrest. So what was good and bad about the experience? So, like I said, there was a couple of times when I had the arrest, and both times I had forgotten that minute of apnea, and that was really bad because, like I said, under the pressure, that was just what I forgot. I just plain out forgot to do it. I knew it's part of the guideline. I know the approach that it should be included, but under that pressure, under that circumstance, switching guidelines, yet still keeping in mind that it is caused from asthma and we need that minute of apnea, and also keeping in mind with respect to ventilations and what you might need as far as a reduced tidal volume and sort of a reduced rate, to keep that in mind, because asthma at the end of the day is the cause of this arrest. We know it's not cardiac failure necessarily, it's an asthmatic cause. So I was not happy with that, but I did get that right most recently, and the tutor said virtually a perfectly or very well run traumatic arrest from asthma. So I was very happy with that. What was good was the fact that I feel every time I've done it in class, I've managed the conscious asthmatic patient very well, in terms of managing the bronchospasm, getting the drugs on early, getting your salbutamol, getting your atropine on, but also reassuring the patient and getting a really thorough history and a history of their asthmatic attack. I feel I've got my line of questioning down to a T now. So analysis. So what sense can you make of the situation? Like I said, I guess with in terms of asthma, it's really that switching gears into traumatic arrest. Not traumatic, asthmatic arrest, and that you have to immediately click into the alright, let's get 2-minute rotations. We need another crew definitely on scene, which should have been called for earlier. Let's get our 1 milligram of adrenaline. So you're dealing with the same drug in different doses via a different route. So that really needs to be emphasized, that it is a change in guidelines, but you still need to remember that it is caused by the original asthma. So what else could I have done was definitely that minute of apnea. That was pretty much both the main arrest times I did in class I did forget, and that's really not good. But I feel like I've drummed it into my head enough times now that if it was to arise again, that I would definitely focus on that and get that done. I also could have called for backup early the first time I did it, because I got into the situation where the arrest occurred and I was calling for backup, and then rightfully the tutor said, well, backup and another crew or marker and another crew are still 10 minutes away because this is the first you've called for them. So would have definitely done that differently. And then obviously finally, if it arose again, what would I do? So I've got my clear outline of critical thinking approach, which I would definitely implement, including that minute of apnea. Conscious asthmatic patient I'm pretty comfortable with the atrovent and salbutamol, with the doses and everything, and doing a full RSA. I've become very, very systematic at the RSA, which I'm very happy with. But yeah, that minute of apnea I would definitely implement. Would be, a very, very important thing to include, because, there may be a chance that you fix that minute of apnea and then you've reduced the pressure so the heart can function again properly, because as I said, it's not a cardiac failure that's causing this arrest. It is asthmatic causes, and the heart can no longer function properly as a result of that. So you still need to keep that underlying cause in mind. So yeah, there are a couple of things I would definitely do again in the future, and as I said, the last couple of times I've done it in and out of class have gone very well, so I'm quite happy with that. But I feel like reflecting back on the semester with asthma, especially my understanding and my approach to managing it has changed so significantly that it's very, very different from what it originally was. So I'm happy with my management of asthma at the moment.